invite our next speaker, Dr. J. Sarvavinothini, who is a senior consultant in Mayot Hospitals, Chennai. Madam finished her undergraduation from Tanjavur Medical College and post-graduation from Madurai Medical College. She passed out as a university gold medalist and worked as a senior resident in AIIMS, then as assistant professor for 3 years in NMCH Nellore and consultant in Mayot since 12 years. She has presented papers and lectures and conferences and webinars. She is the associate editor of Online Anesthesia Program and has published papers in national and international journals and also is an examiner. Her areas of interest are pediatric anesthesia, obstetric anesthesia and NORA, outside operating.
Thank you. Am I audible? Yeah, thank you for the nice words, ma'am. I thank the organizers for providing me this opportunity to be before you. The topic for today, physics of ultrasound. We generally hear sound, but now we tend to look inside our body using sound. To know how, it is important for us to know about the physics of ultrasound. Ultrasound, is it audible? It is beyond the audible frequencies. So it is beyond 20 kilohertz, and the normal diagnostic modalities that we use is beyond 1 megahertz. So first let us see the properties of sound. For the sound needs to be propagated, so it needs a medium to be propagated. The particles as such aren't propagated, it's only the vibrations and the energy that are propagated. Sound travels like a longitudinal wave, so there is alternate compressions and rarefactions occur for the sound to be transmitted. So if you're going to plot this as a wave, and if we find out two similar points in the wave, the distance between those two similar points gives the wavelength, and the number of waves that happen per second is a frequency, and the height of the wave gives us the amplitude, and the speed is called as the velocity. So these are the four important characteristics that we need to know. So if you have to maintain the velocity as constant, then there has to be simultaneous change in the wavelength and in the frequency, and it has to be inverse. Meaning, so let us see here if you are going to change the frequency. So let's see in this picture, if it is going to have a constant velocity, here we have a low frequency and here we have a high frequency. So let us see what happens to the wavelength now. So we can see here, when the frequency is low, it has to take a longer wavelength to achieve the same velocity. And when the frequency is high, it has to have a shorter wavelength to achieve the same velocity. So low frequency has a longer wavelength and high frequency has a shorter wavelength. Why is this important for us? The low frequency probes or the curvilinear probes, they can penetrate deeper because they have a longer wavelength. So we use the curvilinear probes to image deeper structures, and the linear probes or the high frequency probes, they have a higher frequency and hence have a shorter wavelength. So we use them to image the superficial structures. And is the speed of the sound same in all the tissues along our body? It depends upon the kind of the medium through which the sound passes. The velocity depends upon the elastic property of the medium and the inertial property. Elastic property meaning how stiff that kind of a tissue is, and density meaning inertial property meaning how dense it is. So as the stiffness increases, the speed increases, and as the density increases, the speed reduces. And we have to remember here that the stiffness plays a more important part than the density. So we can see here air being not so stiff has a velocity of around 330 meters per second for sound, and bone being very stiff has the highest velocity, and all other tissues have average about having 1540 meters per second. So the implication for us in this is the speed of the sound in air is the least and the speed of the sound in bone is the most, and all other soft tissues it averages around 1540 meters per second. So how is ultrasound produced? We all would say it is produced by piezoelectric effect, which is actually wrong. Piezoelectric effect means the sound vibration is being perceived by the piezoelectric crystals and it's being generated as an electrical voltage. So the piezoelectric effect actually is used to receive the transmitted echoes. The actual way how the ultrasound is produced is using the reverse piezoelectric effect, wherein you give an electrical signal and the piezoelectric crystals are vibrated to produce ultrasound. So an ultrasound can act as a speaker and emit the sound vibrations using the reverse piezoelectric effect, and it can act as a microphone and receive the transmitted echoes using the piezoelectric effect. But we need to remember that an ultrasound transducer can only do one thing at a time. It can either send signal or receive signal. It cannot do both at a particular point of time. In the transducer, the active piezoelectric element is being sandwiched between two layers. And here we can see that either transmission or listening to the received echo. So only that can be done at any particular point of time. So, and here we can also see that the high frequency probes has a higher listening time when compared to the low frequency probes. So the second clinical implication comes here now. So the high frequency probes has got a higher resolution because it can listen for a longer time. So there are Humpty number of probes. The common probes that we use are the linear, curvilinear, and the phased array probes. As we have seen earlier, linear probes can penetrate deeper than the curvilinear probes. And as we discussed shortly before, linear probes have got a higher resolution also because they tend to have a higher listening time. So as the frequency increases, the penetration reduces and the resolution increases. So the linear probe is used to image superficial structures with the highest resolution. And the curvilinear probe is used to image the deeper structures with okayish resolution. And the phased array probe is for the cardiac structures, which needs a very good penetration, and the resolution is not so good there. So now the sound has been generated. So now it's going to be transmitted into our body. So what happens there? One of these four things can happen. It can either get reflected, scattered, refracted, or absorbed. So before knowing all these things, we should know about what an acoustic impedance is. Acoustic impedance means there's a resistance to the passage of the ultrasound wave across our tissues. So the acoustic impedance is least for the air, so it can easily pass through the air, and it's the most for the bone. So it has a difficulty in passing through the bone. Than the acoustic impedance per se, it is the acoustic impedance difference, or the difference between the acoustic impedance of two tissues, that is important, because that is going to determine how much of the wave is going to be reflected between each surface. So let us take an example here. Let us have two tissue interfaces having two different acoustic impedance. If there is no difference in the acoustic impedance, if both are same, almost all the waves get transmitted. If the difference is going to be huge, most of the waves get reflected. So let us extrapolate this with muscle and other tissues. So with regard to muscle and fat, both having almost same acoustic impedance, we can see here more than 99% of the waves get transmitted, and only 1% gets reflected back. In contrast to muscle and air, where we can see how huge the acoustic impedance difference is. So here only 1% gets transmitted across, and more than 99% of the waves get reflected back. So it is the difference in the acoustic impedance that is more important. That provides us the contrast. We don't use contrast for ultrasound, right? We use contrast in CT and MRI. So these acoustic impedance mismatch gives the source of the contrast. So the acoustic impedance mismatch, when it is large, that is the source of reflection. So if it is huge between soft tissue and air and soft tissue and bone. Where do we apply it clinically? We use gel to remove this acoustic impedance interference of the air. So to remove those air pockets, we use gel or saline when we perform our ultrasound. And it's almost difficult to image behind the bones and impossible to image across the bowel gas because of this acoustic impedance. What is refraction? It is also similar to the reflection that we have spoken about, but here the acoustic impedance is not that very huge. It is just slight. So because there is a slight difference in the acoustic impedance, what happens is the speed of the sound waves gets altered. Because the speed of the sound waves gets altered, the course of the sound wave is also altered. So it just gets refracted. It changes its direction. This leads to refraction and many other artifacts, which we'll discuss shortly. The other thing that can occur is scattering, which occurs when the surface is irregular or when there are multiple tiny things like RBCs or other things in between. So they generate numerous low amplitude echoes. So this scattering is responsible for the speckled or the textured appearance, or for the tissue specific signatures that we get for kidney, liver. All these things is because of the scattering. And the last one is the attenuation. Attenuation or absorption. It means how difficult it is for the ultrasound to pass across that. The energy of the ultrasound is being absorbed. So the attenuation is more for air and for bone. In air, all the energy is being absorbed by the air. And in bone, most of that gets reflected back. So the attenuation also corresponds to the frequency. If you're going to use a high frequency probe, it attenuates more. Means beyond that, beyond a particular depth, you cannot receive the ultrasound waves at all. A low frequency probe hence can go for a low, can penetrate more. So this is also another reason why you use a low frequency probe for imaging deeper structures. So these are the four things that can happen with an ultrasound wave: can get reflected, refracted, absorbed, or scattered. So now that interaction has happened, how do we get an image? What does the ultrasound know about the echoes that it receives? It knows how loud that echo is. So it can plot an amplitude of the receiving echo.
It knows how much time it has taken for the echo to come back. So depending upon that, it can plot at what depth that particular echo has come from, and it knows the pitch or the frequency. The echogenicity or the grayscale depends upon, like it is like a comparative thing. Like if the returning echo is equal to the surrounding structures, you get an isoechoic dot, like for kidney, liver and all. If the returning echo is going to be much lesser when compared to the surrounding structure, almost no returning echo, then you plot it as an anechoic dot, like blood or fluid. If the returning echo is going to be very high compared to the surrounding structures, we get it as an hyperechoic dot, as we get it for fascias and bones. So what are the modes that we use? The amplitude mode, wherein the returning echoes are just plotted as amplitudes. So this is the A scan that we commonly use in ophthalmology. This can only give us an idea of the distance between those tissues. Nothing much we can get beyond this. So how to change this to the B scan or the common scan that we employ in our theaters and ICU. So these amplitudes are then plotted into the echogenic dots. So as the amplitude is higher, you get a more echogenic dot. As the amplitude is lower, you get a lesser echogenic dot or an anechoic dot. What is M mode? So along this 2D image, if you plot a line, and along that line, if you want to know how the tissue planes move, that gives us the motion mode. This is used in cardiology to know the movement of the tissues along the different planes, and it's also used in the lungs, in our normal lung scan, to determine the pneumothorax or the lung sliding sign. So how is an amplitude image being converted to the brightness mode or the normal 2D image? The reflected echo is plotted as a dot. The strength, depending on the strength, the brightness of the dot corresponds to the strength. And from wherein the returning echo has originated, that determines the position. So all these along numerous lines, it is being plotted together, and it moves at a 24 frames per second and gives us as a continuous image, giving us a real-time scanning. The time gain compensation knobs that we often use, that is to compensate for the attenuation that we spoke about earlier. So as the ultrasound waves pass deeper and deeper, we can see here that the signals lose their intensity. So to overcome that, we can use this time gain compensation, where we increase the gain to the deeper tissues, and we can see the difference here. We'll be able to image the deeper structures better. So what is Doppler effect and Doppler shift? If there is a stationary source of sound, and if there is a stationary observer, the wavelength and the frequency is equal in both directions. Now, if the source of the sound is going to move towards the observer, we can see here that the frequency increases and the wavelength reduces, and the opposite occurs on the other side. So we can correlate this to the moving RBCs. So if there is an RBC that is going to move towards your ultrasound transducer, it is going to emit the returning signal at a higher frequency than what was transmitted to it. If the RBC is going to move away from the transducer, it is going to emit the signal at a lower frequency than what it actually received. So this gives rise to the Doppler shift. So what is Doppler shift? It is the difference between the frequency that has been received minus the frequency that was originally transmitted. So if the RBCs are going to move towards the transducer, the returning frequencies are going to be more than what it actually received. So it is going to have a positive Doppler shift, which is going to be depicted as a red color in the ultrasound. If the blood is going to move away from the transducer, then the RBCs are going to emit the frequencies at a lower frequency range than what it actually received. So the difference here is going to become negative. So that will be plotted as a blue color in our ultrasound image. The artifacts and the bioeffects. Does the ultrasound know everything about whatever the echo that it receives? It assumes many things. It assumes that sound travels at a constant speed. It assumes that sound travels in a straight line, and it assumes that the attenuation of sound is uniform. Is this all correct? It is all not 100% correct. It is closer to the truth. That is why we get real images. But these assumptions also gives rise to the artifacts. These artifacts can be a boon or a curse for us. There are numerous artifacts. We'll go through some of them. The refraction artifact. The refraction artifact occurs when there is a change in the direction of the beam direction. This we saw earlier. There is a slight difference in the acoustic impedance between two tissues. That is when the refraction artifact occurs. What happens here is, let us presume this is wave number 1, which travels and hits the true object and sends back an echo. So here this image is being plotted correctly by the transducer at this particular point. So fine. Now there is another wave which encounters a tissue that is capable of refracting it. So now what happens, instead of taking this path, this wave gets refracted and it changes its direction now, and it comes and hits this object again. So it carries the returning echoes, and but what the ultrasound assumes, it doesn't assume this refraction at all. The ultrasound assumes that sound travels in a straight line only. 2 more minutes, ma'am. It assumes that sound travels in a straight line only, so it just plots the image assuming that sound has traveled in a straight line. So you get an artifact. So refraction artifact occurs along the same depth. So here we can see the example. We get 2 iotas. This is a real iota and this is the artifact. That has happened because the fat here had refracted. Mirror artifact is also similar to the refraction artifact, but the difference here is there is a surface which is highly reflective here, and the artifact occurs as a mirror image, so it occurs at a different depth. In refraction, it occurs at the same depth. Here we can see it is occurring at a different depth. So this is the normal wave, and this is the one that has been reflected by the highly reflecting surface. And so, but the ultrasound doesn't take into account that reflection or refraction at all, and so it plots an artifact here. Reverberation artifact that we commonly seen, that is commonly seen when there is multiple reflections and refractions occurring between 2 high reflective surfaces like pleura and all. This is seen as the A lines in our normal lung scans, and the reverberation artifact also occurs with our ultrasound block needles. So the characteristic feature here is the echogenicity keeps on reducing as we go deeper and deeper. The comet tail or the ring down artifact is also similar to the reverberation artifact, wherein the accumulation of a little fluid in the septa and just beneath the pleura, all those things, or thickening of the interlobular septa. So those things will cause multiple reverberation artifact to occur, and that is that gives rise to the B lines. So this goes through and through the whole screen. The acoustic enhancement or acoustic shadowing occurs when there is a low or high attenuation respectively. So when there are regions of low attenuation, like behind the vessels, we can see the acoustic enhancement. We can see more ultrasound waves concentrating there, so that leads to the acoustic enhancement. And when there are structures of high attenuation like bones or gallstones, we can see shadowing happening there. The bioeffects are very, very minimal of ultrasound. It is like there can be some rise in temperature which can be measured as thermal index, or the cavitation of the gas bubbles that can occur. But these are very, very minimal compared to all other diagnostic imaging modalities. So the take-home message is, the properties of ultrasound, the velocity depends upon the frequency and the wavelength. So when the frequency increases, the wavelength has to reduce to maintain the constant velocity. The ultrasound is produced using the reverse piezoelectric effect, and the interaction of the ultrasound with matter, the air has the slowest sound, and the bone has the highest velocity of sound, and all other soft tissues have an average speed of around 1540 meters per second. The formation of image, it is the difference in the acoustic impedance that is more important than the acoustic impedance per se, and that gives rise to the source of contrast. The Doppler effect and the Doppler shift is the difference between the returned frequency and the transmitted frequency. So it is blue when it is going to move away from the probe, and it's going to be shown as red when it's going to move towards the probe. The artifacts can be a boon or a curse for us, and the bioeffects of the ultrasound are minimal. Thank you for listening to my vibrations. Hope all got transmitted and absorbed and not reflected. Thank you.